Dr. Chaitanya Dev, please.
Good morning to all of you and respected judges. Today I am presenting on role of NMR spectroscopy in recurrent and aggressive giant cell tumors. Giant cell tumors of bone account for 4 to 5% of primary bone tumors. It has got predilection for the epiphyseal or metaphyseal region of the long bones. And after intra-regional procedures, the local rate of recurrence varies from 10 to 40%. Surgical indications for the management of annealing stage 1 and early stage 2 giant cell tumors are very well defined. But management of annealing stage 3 and particularly late stage 2 is quite controversial. So we took this group into our study. Many clinical, radiological, biochemical and histological markers have been used to assess the aggressiveness of this tumor. Example, HRAS, P53, DNA ploidy, etc. MR spectroscopy basically involves the assessment of the choline peak levels. And this assessment of the choline level in MR spectroscopy has been found to be useful investigation in brain tumors, cervical cancers, neck tumors, and soft tissue tumors. But the usefulness of MR spectroscopy in bone tumors is still not established. Our aim and objective was to investigate whether presence of a choline can be used to predict the biological behavior of giant cell tumor of bone. Ours was a prospective cohort study which was done in Department of Orthopedics AIMS from November 2010 to January 2013, and total 31 cases of recurrent and aggressive giant cell tumors were taken. Inclusion criteria was histologically proven aggressive GCT of long bones, spine, pelvis, except hand and feet lesions, and recurrent primary giant cell tumors of long bones. Exclusion criteria was GCT of bones of hand and feet, radiologically primary grade 1 and grade 2 giant cell tumors of long bones. Single voxel spectroscopy data was acquired at echo times of 30, 135 and 270 milliseconds. In case of heterogeneous and big tumors, volume of interest was carefully positioned to include the early enhancing areas of the tumors. Choline was considered to be positive if definite peak of choline was present at 3.2 ppm in MR spectra at any of the 3 echo times. From total 31 patients, 2 patients were lost to follow-up, 2 patients didn't cooperate, 19 patients were females and 12 were males. Our study group consisted of 13 patients of aggressive GCT and 18 patients were of recurrent GCT. Our study was having maximum number of patients in the age group of 25 to 29 years. And maximum number of patients were treated with curettage and bone grafting. In a recurrent GCT group, there were total 18 patients, out of which choline was positive in all 15 cases. Data was lost in 1 patient, and in 2 patients, study was not completed. In aggressive GCT group, there were total 13 patients. Choline was positive in 11 patients. Data was lost for 1 patient, and 1 patient choline was absent. Now some case studies. This is a case of a proximal hubrin giant cell tumor. And you can see very nice choline peaks in all the 3 TEs. And for this patient, we did excision and shoulder hemi-replacement arthroplasty. Now another case of a GCT of proximal end of radius. Very nice choline peak levels are seen at all the 3 echo times. That is 30, 135 and 270. This is another case of a GCT of distal and femur. And you can see the choline peak level is present only at 1 echo time, and other spectra is very noisy. As this is the choline peak at 1 TE time, and this is the other spectra which is very noisy, and signal ratio is very similar to the noise ratio. And for this patient, we did resection and arthrodesis. This is another case of GCT distal and tibia. And we can see choline peak is present in all the 3 T echo times. And for this patient, we did curettage and bone grafting. Now, one example of a good choline peak with high signal to noise ratio. We can see choline, very nice choline peak and very less noise ratio. This is also very good choline peak and very less noise. This is another example of choline peak present with low signal to noise ratio. And you can see in all the three echo times, there is a lot of noise and very less amount of signal is present, although it is present here, which can be considered as a significant. Very limited amount of work has been done in this field. There is only one study which was published in American Journal of Radiology in 2007. It consisted of 33 patients, 12 patients were of a giant cell tumor, and only 4 were found to be having elevated choline levels. Out of these, 3 were aggressive giant cell tumors. This is another study signifying that choline SNRs were different for malignant and benign lesions. In conclusion, we can say elevation of a choline level is found in most of the aggressive and recurrent GCTs. Choline can be used as a marker to predict the biological behavior of GCT of bone. Presence of choline can help surgeon to plan treatment of aggressive and recurrent GCTs. Although studies with large sample size, definite control group, and longer follow-up are required to confirm it. Take-home message is, choline presence definitely provides an idea about the aggressiveness and possibility of a recurrence before surgery. Hence, it can help surgeon to amend the required treatment according to more appropriate biological behavior of tumor rather than radiological details. Thank you.
Thank you, Chaitanya. And we suppose that we'll have the discussion or questions at the end. You can sit.
Thank you, sir. Thank you very much.
Dr. Anup. Is open for discussion. Any queries?
Yes, Dr. Rastogi, any query?
Gopalakrishnan from Trivandrum. Can I ask you that the type of curettage, intradivisional curettage, is standard curettage or an extended curettage you have done?
That depends upon the previous picture or radiological details. We usually had an extended curettage in all the patients, usually. These were aggressive patients, aggressive GCT, so we had an aggressive extended curettage and bone grafting was done. And local adjuvants like hydrogen peroxide was also used. Burr and high-speed burr and local adjuvants like hydrogen peroxide, phenol, etc. was also used at the time of, depending on different patients.
How do you select the appropriate adjuvant?
We usually do in all patients hydrogen peroxide. First, with high-speed burr, we curate out all the surrounding area. Then after we apply the hydrogen peroxide burr for hydrogen peroxide for soaked mops for around 1 minute or so. And then we instill the phenol. In all the patients, this was the procedure done. This is basically a proton MR spectroscopy. It is done on MRI machine itself, and the software is provided only by the machine. Like we did it in Siemens machine, and they provide the MR spectroscopy software also. In this, there is a proton. When we apply the magnetic field, then the protons which are present inside in the cell, they get stimulated. Like they have got their also magnetic property, the positivity and negativity. So they get influenced by that magnetic field. And whenever we apply higher fields, they get stimulated to a particular direction, all protons. So a spectra is obtained when we give a magnetic field, then after definite relaxation times, like we know there is a definite T1 and T2 images. According, the relaxation time depends of a different substitutes and constitutes of the cell. Like we have N-acetyl aspartate in the cell, we have phosphorus, we have a proton, and everybody gives a different relaxation time, reverts back, echo which we say, it comes back at different intervals. So we get a spectra. And in this particular thing, we are using the phosphorus as a molecule, which is usually present in the choline molecule, which this choline molecule itself is present in the membranes of the cell. You know, basically the membrane is formed by the choline. If at all there is increased replication of the cells, as we know in malignant tumors or aggressive tumor, there is increased proliferation of the cells at one particular time, and aggressiveness goes by that. So that choline concentration will be more, theoretically. and that phosphorus will be more. And if more number of phosphorus nuclei are present at one, like voxel image, which we say, a voxel which is placed in MRS, we usually contrast and enhanced MRIs for this. And in that contrast enhanced MRI, early enhancing areas are selected. That enhancement is particularly focused, and in that particularly enhanced areas, this phosphorus molecule is, when it gives back the echo time, then there is a definite peak at 3.2 ppm hertz. This is basically hertz, 3.2 ppm hertz. And at that particular time, if peak is present, that means significant amount of choline is present. We did only qualitative analysis. Quantitative analysis has not been done yet, and no particular guidelines are still present. This is a preliminary study which we are focusing.
Thank you, Chetan.
Thank you.
So next speaker, Dr. Anu.
Topic is osteosarcoma. Where do we stand in a 10-year follow-up of 110 cases?
Good morning, everybody. I bring warm greetings from Kerala, God's own country. And we'll be talking about osteosarcoma and where we stand with respect to the survival of these patients based on our experience at SUD Hospital, Trivandrum. Osteosarcoma, we all know, is the most common primary malignancy of bone affecting the young, and its incidence is only 5 per million per year. Its etiology is multifactorial, with both genetic and environmental factors playing significant roles, and it arises from a single previously normal cell which has attained the ability to evade apoptosis. At our hospital, we treated 110 patients with osteosarcoma from 2001 to 2010, and we have a clear follow-up of 70 consecutive patients treated from 2007 to 2010 who were used for the survival studies. After clinical examination and plain radiology, they were subjected to MRI of the locality, which would give us better idea regarding the involvement of the bone and also the soft tissues, which would give us an idea regarding the appropriate biopsy and also plan for the definitive surgery. Preferably a needle biopsy by CM guidance was obtained, and these patients were then worked up using a CT chest to look for pulmonary metastasis and also a bone scan to look for any skip lesions. They were then sent for neoadjuvant chemotherapy at the Regional Cancer Center, Trivandrum, and they undertook 2 to 3 cycles of chemotherapy at 3 weeks interval. These patients were then operated by limb salvage surgery using either endoprosthetic or biological reconstructions. But there were 4 cases of primary amputations because of neurovascular involvement, and these patients undertook 3 further cycles of chemotherapy and were kept on periodic follow-up both clinically and radiologically. The follow-up ranged from 36 to 84 months with a mean of 48.7 months. What did we find? As expected, most of our patients, nearly 80%, fell in the second decade of life with a slight male preponderance. Lesions around the knee accounted for nearly 80% of the cases. There were 10% cases of proximal femur, some cases of the proximal humerus, forearm, fibula, and the ilium. Our pathologists labeled a large number of cases as high-grade conventional osteosarcoma. There were 8 cases of chondroblastic osteosarcoma, a few cases of periosteal, pleomorphic, and telangiectatic osteosarcomas. We tried to gauge the response to chemotherapy according to the Huos grading pulse based on the percentage of tumor necrosis from the resected specimen. And it was quite worrying to see that nearly 50% of the patients had a grade 1 or 2 response, that is a poor response. This study is about the survival of these patients. We tried to find the factors that influence local recurrence and pulmonary metastasis with their ultimate effect on survival. Local recurrence has always been considered surgical failure. We have had our share of failures too. In our series, the local recurrence rate stood at 12.85%, which is slightly higher than the international rates at present of around 6 to 8%. What were the reasons for that? We needed to find out. In our series, the proximal lesions were associated with higher rates of recurrence. Nearly 30% of all proximal femur lesions had local recurrence, while around the knee, the recurrence rate was around 5 to 6%. This is supported in the literature, which says that distal tumor location is associated with lower local recurrence rates, supported by Whalen and Greimer in Annals of Oncology 2011. In our study, there was no significant relationship between the tumor volume and recurrence. This is in contradiction with the international journals, which say that tumor volume in excess of 200 ml is an independent prognostic factor for recurrence and survival. The response to chemotherapy also affected recurrence. It was found that people with grade 1 or 2 response had a higher rates of recurrence. Coming to histological type, in our series, certain tumor types like the periosteal and chondroblastic osteosarcomas had higher rates of recurrence. This is also supported by the literature, which says that prognostic factors is affected by the type of histological typing. Margin, of course, is the most significant factor. In 4 out of the 5 patients who had histologically positive margins returned with a local recurrence in a short period of time, while in patients without a clear margin, the rate of recurrence was less than 10%. There is ample evidence in the literature to suggest that positive margin is the most important determinant of local recurrence. In fact, some papers, as one quoted, goes on to suggest that it is the only factor. Pulmonary metastasis is considered a failure of chemotherapy. Is it quite that simple? Yes, the observed trend was that lung metastasis correlated well with response to chemotherapy, and this is also very well documented in literature. In our study, there was no significant relationship between histological type and lung mets, and a study of the literature returned a split verdict on that. There were both papers for and against that. Does the surgeon contribute to pulmonary metastasis? The answer is possibly yes. In our series, 50% of the patients who came with local recurrence returned with subsequent pulmonary metastasis, while in patients without any local recurrence, the percentage of pulmonary metastasis was much lower. This is also supported by literature. Now we come to the ultimate question, the one of survival. In our series, the overall 3-year survival rate stood at 70.8%. What are the factors that directly affect that? Yes, chemo response is directly linked to the 3-year survival. 100% of the people who had a HUO grade 4, that is 100% necrosis at resection, had a 3-year survival, while in people with grade 1, that is the 3-year survival was around 50%. People with grade 2 and 3 fell somewhere in between. Obviously, local recurrence had a very strong influence on 3-year survival. 3-year survival was 85% in patients without local recurrence, while it fell to less than 40% in patients with local recurrence. The most significant prognostic factor, of course, is pulmonary metastasis. 90% of the patients with pulmonary metastasis succumb to the disease in less than 3 years' time, while more than 80%, that is only 20% with pulmonary metastasis, made it to 3 years. That is obviously the most significant factor. Now, where do we stand based on our study? We do know that systemic control of the disease is basically a factor of response to chemotherapy, and it has not shown any significant improvement in the past several decades. Now, the paradigm shift from cytotoxic drugs to molecularly targeted agents could show us the way forward. What is our role as surgeons? Our role as surgeons is to gain local control through adequate surgical margins, because surgical margin is the single most important factor, and it is the one modifiable factor that is going to affect the prognosis of these poor victims. Meticulous preoperative planning and careful surgical execution can maximize our results and help control this deadly disease. Thank you.
Thank you, Dr. Anu, for nice presentations. Now paper is open for discussion. Yes, Dr. Alok Agarwal.
What are the time limits between the last dose of chemotherapy and the surgery?
3 weeks. 3 weeks.
All the patients are operated within 3 weeks?
Yes, sir.
All the patients are operated within 3 weeks or after 3 weeks?
After 3 weeks. 3 weeks after the last dose.
You have taken a case for surgery.
Yes, sir.
And you happen to accidentally open the tumor.
Yes, sir.
What is your protocol?
Our protocol is to go back and amputate, sir, with the patient's consent. Of course, it is subject to the consent of the patient. Sometimes we have got consent, sometimes we have not got consent. 4 out of 5 patients, I said, one patient has actually, is still surviving. That one patient was the one who actually refused to give us consent for amputation. She is still surviving, God only knows.
The patients were margin positive.
Yes, sir.
Do you go for amputation?
Sir?
Positive
Yes, sir. No, we actually keep them under very strong follow-up, sir. We keep them under very strong follow-up, close follow-up, and then be closely watching for local recurrence.
Any other question? Thank you, Dr. Pillai.
Thank you, sir.
Our next speaker is Dr. Jitesh Kumar Jain.
Good morning, everybody. Greetings from Hyderabad. I'm going to speak on arthroscopic excision of pigmented villonodular synovitis, results of 40 cases with average 7-year follow-up. Introduction. Long way back in 1941, the term PVNS was coined by Zaffe et al. He described the disease as a disease of joints, tendon, and bursae. Since then, there has been a great increase in our knowledge regarding the disease. Now we know this is the hypervascular neoplastic proliferation of the synovium with deposition of macrophages, multinucleated giant cells, and hemosiderin. This is usually a monoarticular disease affecting people in the 3rd and 4th decade. The knee joint is the most commonly involved joint, followed by hip and ankle joints. A yearly incidence of 1.8 cases per million population has been recorded. Etiology, still uncertain, but the presence of aneuploidy and trisomy 7 in the diseased synovial cell favors its neoplastic origin. Literature centrifugal growth pattern and ability to erode surroundings and DNA flow cytometry also support this view. It is basically classified in 2 varieties, localized nodular and the diffuse varieties. Both have common histological features. So far, 20 cases of malignant PVNS have been reported in the English literature. Purpose. Purpose of our study was to evaluate the long-term results of arthroscopic excision of the pigmented villonodular synovitis of the knee joint. Coming to methodology. Our study included 40 histopathology-proven cases of PVNS. All cases were treated arthroscopically during 25 years from June 1997 to August 2012. Patient of PVNS usually have vague signs and symptoms like knee pain, swelling, decreased range of motion. So arthroscopy is both diagnostic and therapeutic. In this series, we present 40 cases, but we suspected it before arthroscopy in only 7 cases. In the rest of them, we made diagnoses like osteoarthritis, meniscal tear, tubercular synovitis, etc. We followed a common protocol for all patients. After clinical examination, X-ray, MRI of the involved joint, and the laboratory investigations including synovial fluid examination were done. But these were not of much help to reach the diagnosis. In almost all patients, synovial fluid was blood stained. Patients were followed at regular intervals and examined for pain, swelling due to effusion, and range of motion. Lisholm knee score were used to functionally evaluate the patients, and Kaplan-Meier life table analysis was done to calculate the recurrence-free survival. Recurrences were diagnosed on the basis of clinical and MRI findings. Coming to results. In our study, average follow-up was 7 years, ranging from 2 to 10 years. Incidence was 0.26%. This is arthroscopic incidence. Male to female ratio is 31:9. Average is 44 years, ranging from 21 to 76 years. The duration of symptoms was 3 months to 5 years. Out of 40 cases, 29 cases were diffuse and 11 cases were of localized variety. The suprapatellar pouch was the most common site for the localization of the localized PVNS. Other were lateral gutter, medial gutter, and the medial plica. Apart from diffuse synovial thickening in the nodular masses, other changes were mainly osteoarthritic changes, like cartilage damage and meniscal pathology. Yes, this is the typical picture of the localized mass of the PVNS. We can see brownish pigmentation, and this is the cut section of the smallest tumor we saw, measuring 3 into 2 centimeters. This is the classical picture of the diffuse variety, brownish pigmentation with the freely movable finger-like filiform villi without any evidence of coalescence. 12 patients of the diffuse variety had their first recurrence between 3 to 12 months. 5 patients had their second recurrence between 14 to 18 months, and the 2 patients had their third recurrence in the 24th month. No recurrence was seen in the localized variety, and no recurrence was noted after 2 years in the diffuse variety. Final Lisholm knee scores were excellent in 31 patients and good in 8 patients. All recurrences were treated by arthroscopic resynovectomy. And this is the final result. Recurrence-free survival probability was 69% at 1 year and 82% between first and second year. Overall 5-year recurrence-free survival probability was 57%. Coming to discussion. Management. This is the most important aspect of dealing with PVNS. There is no gold standard treatment outlined. Many treatment modalities, including arthroscoping and open excision synovectomy, arthroplasty, low-dose external beam radiotherapy, and recently imatinib therapy have been used by various authors with variable success rate. Yes, most important aspect of management is to how to prevent recurrences and how to deal with them. External beam radiotherapy and intra-articular yttrium-90 are usually combined with the surgical excision to prevent recurrences. Imatinib therapy has also been used by some authors. In the most published studies, the recurrence rate of the arthroscopic synovectomy were as high as 50 to 60%, and the median recurrence interval of 5 years after index surgery has been reported. We produced excellent results. In our series, mean recurrence interval was 6.25 months, and first-year survival rate was 69%. Arthroscopic synovectomy, the main benefit is the low postoperative morbidity, decreased pain and stiffness, and also easier access to the posterior compartment. So how did we do? The diffuse variety and the residual disease due to subtotal synovectomy are the well-known factors responsible for the recurrences. So we followed a thumb rule. The golden rule is no macroscopic tumor should be left after synovectomy. In the diffuse variety, we routinely performed arthroscopic synovectomy with 5 portals, anteromedial, anterolateral, high anteromedial and anterolateral, and the posteromedial portal. Localized cases were amenable to excision by routine anteromedial and anterolateral portals. Recurrences, in the study, we found that they can also be dealt with arthroscopic synovectomy as successfully as the index surgery and also with low morbidity. So tips and pearls to reduce the recurrence rate, excision of the diseased synovium from the posterior compartment is very important. In this picture, we can see how efficacious are the oscillating synovial shavers in removing the diseased synovium. This is the picture A before removal of the diseased synovium, and the picture B where the no macroscopic tumor you can see. The strength of study. The strength and distinguishing features of our study are adequate sample size and only one modality of treatment. We used arthroscopic excision for both primary disease and recurrences, and of course 7-year follow-up. Our results are reliable. This is the world's largest series of arthroscopic excision as sole treatment of pigmented villonodular synovitis. We concluded from this study, in the hands of an experienced arthroscopic surgeon, arthroscopic excision gives good result, as good as open synovectomy, and recurrences can also be managed with a good success rate with low morbidity. And recurrences do not affect the functional outcome. Thank you.
Thank you, sir. Thank you for nice presentations. Now paper is open for discussion.
Sir, as I said, we followed a common protocol for all patients. We did clinical examination, MRI, and X-ray. We did routinely arthroscopy in all patients who comes to us with the problem of knee pain, decreased range of motion, etc. We suspected it on the basis of clinical and MRI findings only in 7 patients, and the rest of them we diagnosed it only after arthroscopy. 12 years. 12 years is the longest follow-up. Excellent result. As far as complications are concerned, we only had post-arthroscopic effusion in many patients, but there are no bleeding, infection, and the neurovascular damage, etc.
Thank you, Jitesh bhai. Our next speaker is Dr. Rahul Sapre.
Thank you.
A very good morning to all of you. So amongst all the Goliaths, now it's the turn of little David. My name is Dr. Rahul Sabra, and I'm from SMS Medical College. And among all the big studies, here is a case report. Do we have some problem there? Sorry for this disruption. So the topic is the fibrous dysplasia of calcaneum. A case report. A 15-year-old male presented in the OPD with a complaint of pain in the right heel since 2 months. He was not having any history of trauma or constitutional symptoms, and there was no significant personal and past history. He presented with an antalgic gait, and there are no significant findings on inspection. Just tenderness over the lateral aspect of calcaneum found on palpation. The range of motion, the ankle has a complete range of motion which was painful, and the subtalar joint has a restricted and a painful range of motion. The blood picture, the ESR and the CRP, they were all normal within the range. The X-ray, the first X-ray that showed it showed an osteolytic lesion with a geographic kind of lysis, which has a sclerotic margin. There was no periosteal reaction, and there was no septation. So this is the axial view of the patient, showing sclerotic margins. You can see the thinned out cortex. This was a lateral view where the septations can be noticed. The CT findings confirmed with a homogeneous lytic lesion with sclerotic margins, thinned out cortex with ground glass appearance. These are the findings in the CT scan. So we moved on to the next step, and to confirm it, a biopsy was done, and the biopsy showed it to be a fibrous dysplasia. Histopathologically, there were predominant fibrous tissue with fibroblastic proliferation with the areas of ossification in various shapes. So a surgery was planned. Lateral incision was taken, and intraoperatively a cavity was found to contain grayish-white organized tissue within the confines of the cortex. The contents were completely removed, the walls were curated, and it was filled with bone cement. This is the post-op X-ray of the patient. You can see the bone cement in the calcaneum. Post-operatively, a below-knee plaster slab was applied for 2 weeks, and partial weight bearing was allowed after 2 weeks. Complete weight bearing was done at 6 weeks of duration, and at 1 year of follow-up, so patient is asymptomatic. So a few words of wisdom about fibrous dysplasia. It's a developmental skeletal defect. It occurs in the monostotic and polyostotic forms. It's usually seen in early childhood and adolescent, and commonly seen in the long bones and the ribs as well as the skull, but it is very rare in the small bones, especially the calcaneum. The literature on the fibrous dysplasia of calcaneum is scant, and to the best of our knowledge, only 9 cases have been reported so far in the literature. The 2 of them coming from the Indians, one by Dave in 1968 and 3 by Pandey et al. In 1961. The other cases have been reported by these authors, Isafuki, Revelle, and Shazovics. In all the earlier cases, autogenous bone grafting was done, but in the present case, bone cementing has been done to promote early weight bearing. So the take-home message is fibrous dysplasia in the small bones, although rare, but it is possible. And the second thing is that bone cementing is a potential alternative to bone graft to provide early strength for early weight bearing. Thank you.
Now this case report is open for discussion.
With the thinned out cortices and a subchondral involvement, why do you still prefer bone cementation over bone grafting? With the patient being very young, would you think that bone grafting might have been?
No, though I think the thinned out cortex
and subchondral bone involvement?
This again goes in favor of something hard in the density that should be provided to the patient. Bone grafting will take much more time to incorporate, and this will not help the patient's cause as he's a young patient. He should not be immobilized for too long, and that's the reason we preferred bone cementing instead of bone grafting. Although all the earlier cases which have been reported, I showed it here, they have used autogenous bone grafting.
Well, at 15 years, would you more give preference to normal function rather than early weight bearing, long-term function rather than early weight bearing at 15 years?
At 15 years of what?
At 15 years of age, the patient also 15 years?
Patient is, yeah. I'll go for early mobilization.
Early mobilization.
Yes. So this is just a case. It's a case report. I know this patient since last two years. So at 1 year of follow-up, this study was published, and he's asymptomatic at present. Yeah. Thank you.
Thank you, sir. Our next session is Dr. P.T. Rao medal sessions, and chairman is Dr. N. K. Agarwal and Dr. N. C. Mohapatra.
This session of Dr. P. Tejaswar Rao medal session. It is a great honor for me because Professor Rao was my esteemed teacher and I learned all the orthopedics from him. Now we invite the first speaker. The time is 8 minutes presentation and 2 minutes discussion. All the speakers are to strictly stick to the time. First speaker is Dr. Ajit Tiwari, midterm follow-up of a comparative
Sorry, first speaker is regarding vertebroplasty. I'll just tell his. Percutaneous vertebroplasty for compression fractures in our population. Observation, recommendations, and outcome grading system. Arnab, here it is written as Arnab. No. It is all right. I think the Arnab is the first speaker. That's it.
Yeah, you see, this is Arnab Karnamkar.
No, I tell you why. Arnab, I think there is a misprint even on the outside board. Arnab has submitted the paper for P.T. Rao gold medal. His paper has been wrongly printed as at the bottom.
Okay, this time.
Yeah. Yeah, can we start his time? And Dr. Arnab, please.
Yes, sir. Good morning, chairpersons and all over present here. Today I am going to discuss about the percutaneous vertebroplasty for osteoporotic compression fractures in our own population, that means in Indian people, and some observation, recommendation and a outcome grading system that we have developed. So small amount about the compression fractures. Everyone know these are significantly symptomatic with structural abnormality, thus poses a burden to the society, making them dependent of someone. They adversely affect the quality of life, physical function, mental health, causing depression, and also decreases the survival of those patients. So these fractures are incidence is increasing day by day, and the main reason behind this, there is increasing trend in the geriatric population worldwide. Trend is going to increasing as there is a high life survival. So also we have to think about the society. Society is also changing. There is a huge change. There is a big transformation from the joint family structure to a nuclear family structure. So they have to be able, they have to look after themselves, these elderly persons, and they have to do their all day-to-day activities. So we have to make them able. And someone has correctly said that get the abilities you need to get the most out of life. So we have to think about the abilities and we have to make them able. So we have treated them with percutaneous vertebroplasty, these fractures, and what are the advantages? These are minimally invasive, this is cost effective, and these are fully functional recovery at very earliest, like a tonic you can say, by after just immediately after the procedure there is a decrease of pain and there is least suffering, no postoperative long period there is there. So our material of study was, it was a prospective randomized, 25 patients were selected, 30 fracture vertebra, average age was 63.2 years, male-female ratio, there is increased preponderance of female patients, and we followed up them up to 13.8, that is average follow-up months, and maximum being the 18 months. And we assessed them by visual acuity analog score and Oswestry disability questionnaire, and we have developed a outcome grading system by this. So our method was to, we have treated all the patient using the percutaneous vertebroplasty by unipedicular approach under local anesthesia using the radio-opaque vertebroplasty bone cement, that is 5% hydroxyapatite with PMMA from the same company. So our operative procedure, it was same, it is known to all. The difference was that we haven't used the syringe pump, rather we used small 2 cc syringe, thus minimizing the chance of accidental over-injection of the cement. This was the thing, and after mixing, the syringe are filled with the cement, and we waited until the cement makes loops or threads, just shown here. So loops of threads, then we have injected. So it's in semi-solid condition. So our results, average age of affected males were 6.3 and females were 61.5, which is much lower than the Western studies. And most of the cases, 56% were operated within 2 to 4 weeks, average being 3.72 weeks, and average cement injected was 2.9 cc. And this is the thing we have come out with this. No studies have shown this, that we have observed the time taken for pain relief, and 56% patient, they clearly said that they have pain relief within 10 minutes of the injection of the cement. And this is the osmosis usability questionnaire, and it has come down gradually, and at 6 months also it's sustaining at a lower level. This is the average score, and 54.9% decrease in at 6 months. So visual analog score was also decreased, and at 74.2% reduction at 6 months, and 6 months, at 6 months, 7 patients were 0. That means they were totally pain-free. So our incidence of complication, among these all complications, we have only 2 cement leakage in 2 patients. Now no other complication, and we have developed this outcome grading system by ODQ score and VAS score at 1 month and at 6 months, and we have graded the results among good, fair, and poor. We also added activity of daily living, ambulation, need of analgesia, and patient satisfaction. So assessment can be done at 1 month and 6 months. At least 4 criteria have to be fulfilled to categorize them in good or fair category, whereas a single criteria is enough to call it a poor outcome. So we have assessed, and we have assessed our results, and we came with that 76% good results and 24% fair results, but no poor results by this grading system. So high incidence resulting in increased burden to the society, more of the female patients are getting affected, and significant pain relief in 10 minutes in majority of the patients we got, an average 2.9 cc injected. We have seen cement leakage was observed in 2 cases, and that were injected earlier than 2 weeks. So we should delay the procedure for at least 3 weeks, and 6.3% leakage among the segments and 8% leakage among the patients, which is significantly lower than other studies compared. So these better results in our study is explained by. So we delayed the procedure up to 3 weeks to minimize the chance of cement leakage. We injected the right amount of cement and injected the cement with syringes, not by cement pump, and injected the cement when it can form loops, means in a semi-solid state. Otherwise it can flow through the small cracks of the vertebra. And we kept the stillet with the needle for some time, at least 2 minutes after injecting, to prevent the backflow when you withdraw the needle. So all this leads to the least chance of cement leakage. So that explains the better result in our study. So limitations, there are obviously some limitations. So with the maximum follow-up period of 18 months, we did not face any adjacent level fracture, probably due to the small sample size and short study period. So these are the few cases: fracture D12, fracture L2, L1, and there is cement leakage seen from the inferior border. This is L2, also there is cement leakage. This is D11 and D12, both the segments are cement are shown. So why still we are doing vertebroplasty? Because the whole world has shifted towards the kyphoplasty. Even in India, in maximum places, everyone is doing kyphoplasty. So why we are taking the wrong path, or why we are going to the past? Why we are going different from others? You may ask, main thing we have faced that the factor not going for kyphoplasty was the cost. Our patients are really poor. They can't afford this procedure, means a lakhs of rupees for one procedure. But we can still give the same results by the least cost procedure. So you may ask that this is the old wine in a new bottle. I would rather contradict and say it's not. It's the same thing that timed properly and delivered in the most justified manner. Thus it gives us the best results. So to conclude, I would say the percutaneous vertebroplasty with bone cement is still a justified treatment procedure for the osteoporotic vertebral compression fractures, as it provides early functional recovery with satisfactory symptomatic relief and at a very reasonable cost. So we may not assure this much of thing, but surely we can avoid this thing, at least to give them this in life. Thank you, sir.
Yeah. Any questions? One or two questions? Yes, Dr. Arya.
Sir, the maximum follow-up was it? No, one patient, sir, two or three patients were followed up to 18 months, not all patients, sir. A majority of was 6 months, sir. So actually it doesn't compare, and we haven't find anything similar to this, because it's both qualitative and quantitative. It's a functional assessment of the patient on some hub, because we have included the VAS score, we have included the ODQ score, and we have included the functional capabilities of the patient, such as ambulation, their pain-free life, their ability to do the daily activities. So we have made this, and I think this is rationally a good one. And we haven't got any such score to compare this, sir, actually. Sir, actually the thing is that the heat that emitted by the bone cement, they burnt out the nerve endings within the fracture segments, and that causes the immediate pain relief, mostly, because it has nothing to do with the union of the vertebra. It only gives symptomatic relief and some support. Yes, sir. Yeah. Sir, some patient needed it, but the maximum patient, actually have 25 patients, 12 or 13 patients didn't need any analgesia, but some patient we have to give some tramadol and paracetamol tablets post-op. Pain relief, some patient it was not proper, sir. That was most of the patient that was good pain relief. That I shown that 56% of the patient they have said properly that they have got the pain relief, but few patients they took time.
Right. Yeah. Can we now have the next speaker?
Thank you, sir.
Dr. Mandal, and he's going to speak on short-term evaluation of results of trochanteric femoral nail in comminuted unstable trochanteric hip fractures. Dr. Mandal.
Going to present the short-term evaluation of the results of trochanteric femoral nail in comminuted unstable trochanteric fractures. Unstable intertroch fractures with posteromedial instability and fractures with reverse obliquity is a great challenge for both patients and orthopedic surgeons regarding treatment and treatment outcome. History has provided a variety of implants in surgeons' arsenal, but none are proved to be absolutely effective. Interestingly, the shortcomings of the most widely used lag screw and side plate constructs are the loss of purchase, pulling of the side plate, disengagement of the screw and barrel in 28% fractures, overimpaction of the fracture fragment, significant loss of limb length, and delay in rehabilitation and ambulation as stated in standard literature. The literature also shows the gamma nail and the proximal femoral nail has a failure rate of 7 to 18%. Moreover, the clinical reports of intramedullary nail for comminuted and unstable fractures are very limited in number. In this scenario, we started a prospective and without control study in 25 patients with closed comminuted unstable intertroch fracture, AO classified a 2.2 to a 3.3, and all of them were operated with trochanteric femoral nail. Skeletally immature patients, patients with pathological fracture, open fractures, and with associated neurovascular complications were excluded. Now, in the anatomy of the nail, it is a third generation cephalomedullary nail metallurgy 316 LVM, has a mediolateral implant angle of 6 degree available in various nail diameter with a fixed length of 180 millimeter. provision for 2 proximal locking, and the distal configuration allows static and dynamic lock. Angle between the nail and cervical screw is 130 degree. I am not going into the operative details, these are all self-explanatory. In rehabilitation, we started active quadriceps and active toe and ankle movements on day 1, non-weight bearing active knee flexion. As soon as the post-op pain subsides, partial weight bearing is allowed as soon as possible, but dictated by the fracture geometry, the post-operative reduction and the stability of fixation, usually 3 to 4 weeks. And full weight bearing is advised at 10 to 12 weeks depending on the clinical and radiological evidence of union. We sequentially followed up our patients clinically and radiologically at 3 weeks, 6 weeks, 14 weeks, and then as required for the next 9 months. And functional scoring by Harris Hip score has been done at 10 weeks and 14 weeks post-op. On radiology, we have noted the fracture union, the extent of fracture collapse, medial displacement, neck shaft angle alteration, and the implant failure. And certain index has been done. Among them, one is Garden Alignment Index, where he categorized our patient into 4 categories depending on the immediate postoperative reduction. Also noted the Cleveland Index, measurement of the tip apex distance, and the fracture gap. In results, all of our cases shows union, where 64% cases united within 14 weeks, next 28% cases united in the next 6 weeks, and last 8% cases united beyond 20 weeks. We had an intraoperative guide wire breakage in 1 case and superficial wound infection dealt effectively in 2 cases. Varus deformity developed in 3 cases in the range of 120 to 105 degree. Among them, 2 cases developed limb shortening of 1 centimeter and 2 centimeter. 1 case was complicated by reverse J deformity and the another had hip pain and significant ipsilateral knee stiffness. In Harris Hip score at 10 weeks, most of our patients at good to fair category and some patients at the poor category. But at 14 weeks, most of our patients at the excellent to good category and only small number of patients remain in the poor category. Regarding Garden Alignment Index, we had very good to good reduction in 60% of our cases. Regarding Cleveland Index, we perfectly placed our implant tip at the zone of stability, that is Cleveland zone 5, 6, 8 and 9 in 70% of cases. In our study, the mean tip apex distance was 12.5 millimeter in the average of on the range of 3 to 30 millimeter. A fracture gap was noted in the first postoperative X-ray in 9 cases and most of them in the 3 to 5 millimeter range. In discussion, the cases where we bound to fix the fracture in certain varus malalignment, but at the end of 1 year no implant related complication was noted and we achieved what we desired. Regarding the fracture gap and the low fracture site contact, no significant rotational instability and cutting out of the implant occurred, and we conferred this is a sign for the strong stability of the implant. And most of the cases, fracture impaction was noted around 6 to 8 weeks. Regarding Cleveland Index, where we mistakenly placed our implant in the zone of instability, but no signs of implant loosening was seen at the end of 1 year. Regarding tip apex distance, we had 2 cases with TAD more than 25 millimeter, but no incidence of loss of reduction and neck screw cutout at the end of 1 year. Regarding Harris Hip score, our results are corroborative with the standard literature by Rucker et al. And Lubinak et al. The first case with case 1 with bilateral comminuted intertroch fracture, CT scan was done for better delineation of the fracture fragments, treated with TFN on bilaterally at the same sitting, and the patient has excellent recovery, functional recovery with Harris Hip score achieving 100 at 14 weeks post-op. The case 2 with unilateral intertroch fracture, treated with TFN at 6 weeks, patient can sit and squat cross-legged, and he had a Harris Hip score 75 and 83 at 10 weeks and 14 weeks respectively. Case 3 with unilateral intertroch fracture, treated with TFN at 6 months, patient can walk without pain, can squat and sit in cross-legged, and he had a Harris Hip score 79 and 87. In conclusion, the trochanteric femoral nail, an acceptable minimally invasive and technically demanding implant, when used in comminuted unstable intertroch fractures, are more advantageous than extramedullary devices from the biological and biomechanical point of view, has less complication rate than its intramedullary predecessors, and thus been emerged as a good therapeutic option with excellent outcome. Thank you.
Can I ask you one question before you said your nail has given better results than its predecessors. How is your nail different from proximal femoral nail, which is the standard?
Proximal femoral nail, its length is 240 millimeter, and trochanteric femoral nail has a length of 180 millimeter. certain studies have showed that the proximal femoral nail, there is increased chance of fracture over the anterior cortex because the femur has an anterior curvature, and due to its long length, it predisposes to the fracture. Some studies has confirmed it. And our nail has a short length, 180 millimeter, and it ends before where the femur starts curving, and thus the incidence of fracture is less and almost nil.
Okay. Now, any other questions from the?
Sir, I actually doesn't elaborate much about this. Most of our patients are adult patients, and the skeletally immature patients are excluded. And regarding sex, about 5 to 6 patients were female patients, and the rest are male patients, male adult patients. Both, sir. In our cases, both road traffic accidents and accidental fall were included, and most of the elderly patients suffered. Yes, sir, but those cases I have shown that bilateral intertroch fracture, he had suffered a road traffic accident, sir, and he is a middle-aged male patient. No, sir, there is no incidence of peri-implant fracture. Yes, sir. Yes, sir. Yes, sir. Okay, sir. Yes, sir.
Although we have not compared your results, not when it comes to growth, but still you say that your nail is even superior than your extramedullary device.
Sir, I have.
Just tell me how an extramedullary device in a comminuted setup, because in combination you need to buttress the combination. How intramedullary nail buttresses the combination.
Sir, sir,
you cannot tell me that the bending arm is less in intramedullary nail. That is an experimental setup, not in a live setup.
Sir, actually we first tried the close reduction, and in most of the cases, though there is a large posteromedial fragment which is comminuted and producing the instability, we were achieved close reduction in most of our cases. And where we didn't have the close reduction, we inserted a Steinman pin in the distal fragment.
How an intramedullary device buttresses the
Sir, I buttress with the 2 cervical screws.
By the way, Dr. Mandal, you said the PFN nail was 240. It is available in variable lengths, less than 180, more than 180, 200, 240. All lengths are available.
Actually, these are PFNs are in indents. Okay.
Next speaker, please.
We invite Dr. Jogesh Patil.